It's my pleasure to introduce Professor Giuseppe Viale, who will present treatment selection for patients with equivocal HR2 status and in luminal versus HR2 enriched disease. Quite a difficult title and subject.
Thank you, and let me start this presentation with a personal remark. I got an upgrade to first class today because I've been upgraded from the pathology class to the oncologist class. And please try to take it like an unwanted side effect of this multidisciplinary team approach to breast cancer. And fortunately enough, I had the opportunity and I got some support from my colleagues, and so I'm grateful to Elisabetta Munzone and Marco Colleone for their invaluable support, helping me to present to you the data related to the first simple and the second difficult task of my presentation. The one that I found simple is to discuss about the double equivocal results. According to the ASCO-CAP recommendations in 2013, double equivocal results were defined as tumors with an equivocal immunohistochemical staining, which is a 2+ score, combined with an equivocal in situ hybridization assay, which was 4 to less than 6 gene copy number and a ratio less than 2. In this situation, in 2013, the recommendation said oncologists may consider HER2-targeted therapy for these patients. Of course, the clinical decision as to ultimately consider HER2-target therapy in such cases should be individualized on the basis of patient status, patient preferences, after discussing available clinical evidence. I put a question mark here because we didn't have any available clinical evidence. Most likely, one possibly clinical evidence was derived from the results of the B47 trial, which included patients with double equivocal results. And this trial, as you know, ended up with no benefit of trastuzumab for those patients with low HER2, including the double equivocal results. So the ASCO-CAP panel has been reconvened more recently, and we have reviewed the definition of equivocal results with immunohistochemistry and in situ hybridization. With immunohistochemistry, may I tell you that this clock does not work at all? So either you count for me. So in terms of immunohistochemistry, we confirm that the equivocal results by immunohistochemistry score 2+ is a weak to moderate circumferential staining of the cell membrane in more than 10% invasive tumor cells. But when we went to the in situ hybridization results, the consensus was that for patients with this dual equivocal results, which means 2+ by immunohistochemistry and a gene copy number between 4 and 6 with a ratio less than 2, whenever this has been confirmed by reading additional cells, by having a second reader to confirm the findings, then in this case, when there is a confirmation of these results by in situ hybridization, we should consider the tumor as HER2 negative. So for the time being, there will not be any double equivocal results to be discussed in the multidisciplinary team approach, and so we will get rid of this problem of double equivocal HER2 status. So these patients will be considered to have a HER2 negative breast cancer. Let's go now to the issue of heterogeneity of HER2-positive breast carcinomas. I think we have two different sets of heterogeneity. The one I call intratumoral heterogeneity. So within the same tumor, there may be spatial heterogeneity when there is heterogeneity within the primary tumor or between the primary tumor and synchronous metastasis. There may be a temporal heterogeneity when there is a difference between the status of the HER2 status in the primary tumor and in metachronous metastasis. And this is heterogeneity within a given tumor. And then there is heterogeneity between different HER2-positive breast cancers. And this kind of heterogeneity may be the co-expression or no of hormone receptors, and of course the different molecular subtypes of HER2-positive breast cancer. The prevalence of tumors co-expressing hormone receptors is a bit variable in the last years, but you see that in more than 60% of HER2-positive breast cancer, there is a co-expression of estrogen receptor. This has been a common finding in all the clinical trials for HER2-positive breast cancer. In the ERA and the original American studies, this was based on local testing. But in the subsequent studies, where we had the privilege to act as central lab, we had in Alto and Affinity, which is in the adjuvant setting, and Berenice and Federica in the neo-adjuvant setting, it is consistently shown that approximately between 60 and 65% of this tumor will co-express estrogen receptor. Almost half of the HER2-positive breast cancer also will co-express progesterone receptor. And so they will qualify for the so-called triple-positive breast cancer. So the numbers are quite important, and this has been possibly correlated with the intrinsic subtyping of HER2-positive breast cancer. But please take note that these two tests, these two assays, they are completely different. We cannot compare pears and apples. The immunohistochemical assay tells us that there is a protein in the cell membrane or in the nucleus, and they don't tell us anything about the activity, the function of that protein. The protein is there. The gene expression profiles, they are modules that explore the activation status, not of one single protein, but of the relevant pathways. So they are completely different. So it is not surprising to me that what I'm calling HER2 positive because of immunohistochemistry or in situ hybridization assay, it will be dissected by the molecular subtyping in different subtypes. And we have already data which tells us that there is no overlap, there is no strict correlation between immunohistochemistry and gene expression profiling. Almost 15 to 20% of tumors that are clinically ER negative, actually they are luminal with the gene expression profiling. And maybe half of the cases that I will call estrogen receptor positive, they will indeed cluster within the HER2 enriched subtype. So what are these dual or triple positive tumors? My way of looking at them is like a hybrid car. These are tumors that, to me, they have two different engines. And the two engines may work together, or one may take over the other, at least for some time, and then the reverse will happen. So the other one will take over the first one. So we have to somehow to try to address and to design our therapies according to these two different engines. These two engines or these two pathways, they have a very important bidirectional crosstalk. We know that HER2 is associated with resistance to hormone therapy. We know that HER2 induces phosphorylation of ER. We know that ER is an escape pathway to anti-HER2 therapies. And HER2 non-genomic estrogen receptor, non-genomic estrogen receptor may induce phosphorylation of HER2. So you see how many crosstalks there are among these two different pathways. What we know also in terms of response to the therapy, in the neo-adjuvant setting, it has been already discussed here, we have lower PCR rates in the ER-positive tumors as compared to the ER-negative, independently of the type of anti-HER2 treatment, either trastuzumab alone or dual blockade with pertuzumab or lapatinib. This different sensitivity to the anti-HER2 treatment in the neoadjuvant setting may help us to design more specific treatment options in the neoadjuvant setting, especially trying to avoid systemic chemotherapy. Indeed, for those tumors that are HER2 positive, hormone receptor negative, that almost resemble the HER2 enriched by molecular assays, we know that the dual HER2 blockade without chemotherapy may achieve some 20–30% PCR rates. And for those tumors that are HER2 positive, hormone receptor positive, we know that TDM1 plus endocrine therapy may achieve more than 40% PCR rate. Okay, TDM1 is chemotherapy, it's not systemic chemotherapy, but look at the use of lapatinib trastuzumab letrozole or trastuzumab pertuzumab letrozole. This is no systemic therapy, any form of chemotherapy, and we have achieved PCR rates from 20 to 32%. So this different sensitivity of these different subtypes may help us to define new therapeutic options in the neoadjuvant setting. How about the adjuvant setting? In the adjuvant setting, I didn't find evidence of interaction between the hormone receptor status or intrinsic subtypes and treatment effect of trastuzumab alone or dual blockade. Most likely this is because of the concurrent endocrine treatment, because maybe these entire two drugs may have different mechanisms of action in the neoadjuvant setting as compared to the adjuvant setting. As an exception, we have seen that there is a less magnitude of the trastuzumab benefit in those tumors that are estrogen receptor positive and have lower levels of HER2 gene amplification. This has been seen in the HERA trial. But the lack of interaction between hormone receptor status and response is also been seen with the adjuvant TDM1 in Catherine. And quite surprisingly, it may well be that there is a better response of ER-positive disease to extended therapy with neratinib, as we have seen in the extended trial. In the advanced setting, expression of estrogen receptor in more than 30% of tumor cells has been associated with a reduced probability of response to chemotherapy as trastuzumab. And in that setting, the maintenance endocrine therapy to women with this kind of tumor has been associated with a significant reduction in the risk of progression. The dual blockade of HER2, trastuzumab and pertuzumab, together with an aromatase inhibitor, is effective for the treatment of these tumors that are HER2 positive, ER positive in first line, as we have seen in the PERTAIN trial. So this is what we have already seen, and now we have new treatment options that are based on different evaluation of these subsets of HER2-positive breast cancer. We know that estrogen receptor and HER2 signaling pathways will exert a synergistic effect on the cell cycle checkpoints. There are multiple feedback loops between these pathways, and so the idea is that maybe triple blockade of estrogen receptor, HER2, CDK4/6 may be a novel and effective strategy. This has been seen in the neo-adjuvant setting. Luca Gianni has run the NAFER2 study, and likely in the advanced setting, which was seen in the Patricia trial. Also, when we are dealing with new possible treatment options, we have already discussed that HER2-positive breast carcinoma may have substantial amounts of tumor-infiltrating lymphocytes, together with high expression of PD-1 and PD-L1 and other checkpoint molecules within the immune cell population. So the idea is that the combination of pembro and trastuzumab may be safe and active in patients with PD-L1 positive, trastuzumab-resistant advanced disease in the Panacea trial that has been discussed by Shirin. Dual targeting with trastuzumab and pertuzumab and anti-immune checkpoint agents, maybe atezo or pembro, is currently being tested in the neoadjuvant setting. We have the APT-NEO with atezo and the NEO-HIP trial with the pembro. So my take-home is that HER2-positive disease is highly heterogeneous. We have intratumoral as well as intertumoral heterogeneity. This dual positive or triple positive breast cancer is a distinct entity because of its biological features, the prognostic implications, and mainly the response to systemic therapies. No discussion, a better understanding of the crosstalk between these different signaling pathways and their feedback loops will pave the way for exploiting new therapeutic options. And despite the clock, I hope I have been within the limit of my time. Thank you very much for your attention.
Yeah. Just one comment while people are trying to reach the microphone. You are definitely upgraded to the oncologist class, Pepe. I'm not sure that's good news for you, but...
Well,
any question?
Pepe, two comments or questions, and that is, shouldn't we start analyzing some of the clinical trials, not only on whether they're HER2 positive by the current definition, but also by the percent positive cells, and looking at the intratumoral heterogeneity? I'm very concerned, for instance, with the TDM1-like drugs, that only the HER2 positive components are going to be killed. And therefore, maybe Taxol would be better combined with Herceptin in such tumors. And I think we're missing an opportunity to look at that in some of these clinical studies, and I wonder what your comment was.
Yes, this is for sure, but as you know, there are currently trials in the neoadjuvant setting which are specifically looking at the intratumoral heterogeneity of HER2 and to assess the response to anti-HER2 treatments. So I think that we will have this kind of answer in the next few months, and this will be very, very interesting. Yes.
In interest of time, we